So welcome to this tutorial on the fractional excretion of sodium and the relative contraindications. We had a previous tutorial where we went in depth into the relative contraindications and why those indications make interpreting the FINA a little bit harder. We're going to just review all of those here in this tutorial and try to hit some of the more common reasons why you have to be careful when you interpret a FINA. If you remember, if you've done the first tutorial, that's great, but if you haven't, don't worry. We'll bring you up to speed on this tutorial. One of the first reasons is the existence of CKD underlying the acute renal failure episode. Remember that CKD means that you have a deficiency in your ability to filter solutes. One of those solutes is sodium. And so if you can't filter enough sodium, the denominator of the equation here for the FINA will be low and the total FINA will be high. Let's do that right here. FINA equals what's excreted. That's sodium that's excreted divided by sodium that's filtered. Now, if you have a decreased capacity to filter sodium because you have CKD, your baseline quote-unquote normal FINA level will be higher than the standard 1 to 2%. So if you calculate a FINA in a patient with CKD who now presents with acute renal failure, you may get a FINA of 4, 5, or 6%, and you won't know how to interpret that because the 1 to 2% baseline is no longer applicable to a patient with CKD. For all you know, the patient could have a baseline FINA of 4 or 5%, and the FINA you've now calculated during the acute renal failure episode isn't that far off from their quote baseline. So CKD patients, you have to pay a little bit more attention to and don't rush to interpret their FINA in the same manner that you would a normal patient who develops acute renal failure. The second large reason is non-oliguria. The FINA is accurate in patients who have oliguria, which is less than 400 mils of blood in a 24-hour period. Anyone who's got more than that or is non-oliguric could have a high FINA for a reason other than ATN. One of the most simplest examples is someone who has a high salt intake. Say, for example, you or I, if we are watching this tutorial right after having a meal, you're probably going to be going to the bathroom if you haven't already, and it's because you've had a lot of salt in your meal that you need to excrete. Your FINA at the time that you urinate will be a lot higher than the quote normal 1 to 2%. That does not mean you've developed ATN after having a meal. That's just a normal response. It's something your kidney is supposed to do, excrete a higher amount of sodium, a higher FINA, in order for you to maintain normal volume status. So anything that causes you to be non-oliguric will make your interpretation of a FINA in the context of acute renal failure difficult. So say you have non-oliguric acute renal failure, a FINA would not be an appropriate test to use. You'd be thrown off and misled. I gave you one example of non-oliguria, and that's high salt diet, so high PO sodium intake. But another one is diuretics. You know that Lasix and hydrochlorothiazide, commonly used diuretics, increase the amount of sodium that's excreted, and that will certainly increase this number here, the numerator, and increase your FINA as a result. And so what we tend to do is perform a fractional excretion of urea on these patients because urea should not be excreted or as affected by the diuretics as sodium is. And we also have a standard baseline level for urea. It's about 30 to 35%. Anyone who's above that in the context of acute renal failure that is oliguric, we say has ATN, and anyone that's below the 30%, we say has prerenal azotemia. most likely due to a diuretic. Keep in mind the fractional excretion of urea is also limited by patients who have CKD, because not only do they have difficulty filtering sodium, but they also have difficulty filtering urea. And these are the most common reasons why you could misinterpret a FINA other than calculating it incorrectly, but we have a tutorial for that as well, a very easy way of calculating the FINA in a way where you don't have to remember all the variables. But if you keep these in mind, I think in clinical practice and on an examination, you ought to be pretty good and won't be misled into coming up with the wrong diagnosis. So those are the relative contraindications, at least the most common ones, for interpreting the fractional excretion of sodium. Thank you very much.